30% cases is anxiety and tension, stress. Others are allergies, uh, deficiencies, especially of iron and folic acid. Most of these ulcers, they are self-healing. They take 10 days to 2 weeks. Whatever you do, mostly they are treated symptomatically with antiseptics, with analgesics, local antiseptic, local analgesics, and some emollients to reduce the swelling in the form of local antiseptics and combination with local anesthetics. They're pretty presentable. They're very common. Second group of ulcerations, chale of the mouth, comes to infective one, and the commonest one are viral one, like herpes, like this one, herpes simplex labialis. These are some of the features of herpes. They also are on the mobile part like lips. It's also known as herpes simplex labialis. We classify into primary, secondary. Secondaries are they are contagious. They can spread from one part to other part or from one person to others. And they are also painful. They come with all symptoms of viral infection like fever, down feeling, myalgias, along with labial eruptions. These are some of the pictures of herpes simplex with multiple eruptions on the lips and around the lips. Traumatic ulcer is another cause. Trauma could be just toothbrushing or sharp end of pencil or ballpoint in the mouth. Common traumas are sharp edge of the tooth, which is piercing all the time whenever the tongue moves during swallowing, during talking, eating. It always hurts the sides of the tongue or the undersurface of the tongue and causes a break in the mucosa. And that prevents the healing of this wound in the tongue until the cause is dealt with. In this case, it's the sharp edge of the tooth. So although the patient is presenting to the ENT subject, doctors, but the treatment lies with the dentist. He has to do something with this tooth. Either round it off or grind it, make it less sharp, or whatever is the treatment he thinks necessary, along with the treatment of symptomatic treatment of the ulcer. Similarly, ill-fitting dentures, braces, or artificial teeth wires can also cause ulcer in the mouth. Presentation will be same, but you try to find out the cause, and obviously we have to treat the cause and symptoms as well. Now the symptom will be treated both by the ENT surgeon by giving the analgesics, painkillers, and dentist himself. Coming to the next group of the causes of ulcers, Behçet syndrome. Now we are studying the autoimmune disorders. And on top of them, this is Behçet syndrome. Now these are all multi-syndrome disturbance affecting eyes, causing uveitis, relapsing uveitis, recurring ulcers on the genitals, and recurrent ulcers of the mouth. These are painful ulcers. They also cause other symptoms of the body, like presented in this slide. Beside eyes, ulcers, genital ulcers, we have joint pains and some skin disorders as well. This is the one of the slides I like more. It tells everything about this disease. It gives a history of the disease. It says what systems are involved and how is it presented and how is it treated. Since it is an autoimmune disorder, it mostly symptomatic treated by analgesics, by steroids, local and as well as systemic. Bassett syndrome. Another syndrome of autoimmune cause is Leishman planus. That's also a common syndrome in the skin dermatology practice. It presents with multiple eruptions on some parts of the skin, also involving oral mucosa, presenting with various presentations like tongue involvement, like side of the mucosa, you can see the lace-like appearance of the mucosa as if somebody has put a net on the cheek. These are the other parts of the body which can have this is Leishman-Planus syndrome. Like you can see the skin things, lot of pigmentation. There are papules, the itchy papules. You can have it on the wrist as well. Look at the nails and mouth as well. So this is a multi-system thing, mostly skin, pigmentations, and oral mucosa. Another disorder of autoimmune origin, basic is pemphigus vulgaris. It's a pretty dangerous disorder where you have a lot of bully on the skin, generalized, along with excuse me, some eruptions on the lips as well as oral mucosa inside the mouth. Known as pemphigus vulgaris. As I said, it's a dangerous condition. It mostly affects the elderly people who have some autoimmune disorders or present to us as the ENT surgeon as ulcers, multiple or one when the blisters rupture. And of course, treatment, since it is autoimmune disorder, goes to the steroids. The steroids are main treatment in a dermatology practice, systemic or local. Now we move to the that concludes our ulceration disorders. I have left with the deficiencies of iron, folic acid, allergies. Allergies could be to either toothpaste or medicines we're taking or dental fillings. There's so many things, But go through your books and complete it. Oral ulcers are very common in clinical practice to the ENT surgeon, to dentists, to general medical physicians, to GPs, to pediatricians, and almost all of you will have to treat ulcers of the mouth. Okay. In clinical practice, people are giving folic acid to everybody. Not everybody, one of us is folic acid deficient, unless you prove or otherwise do not give. Yeah, the common things are definitely deficiencies of iron in our populations that needs to be looked into, as well as some other nutrition deficiency like vitamin D, calcium, and other things. So now we move to pre-malignant pathology. And here I have put these four conditions which are commonly accepted as they can lead to malignant. They are not malignant, but they can lead to. Look at the top. Is erythroplakia, which means something red in the mouth. Next is leukoplakia, which means a white patch in the mouth. Then is oral submucous fibrosis. We'll talk about it. And Plummer-Vinson syndrome. This is a multi-system involvement mostly due to deficiencies of iron in the body. We try to take one by one in detail. This is how WHO has tried to explain what is pre-malignant condition, that it can go and get converted into a proper frank cancer. It is not cancerous as yet, but it may go. So they have a tendency of becoming malignant. These are the proportions of chances of malignancy. You can see the top. On top is erythroplakia, almost more 50%, more than 50%. Then is leukoplakia, followed by oral mucous fibrosis as well as Plummer-Vinson syndrome. This is how leukoplakia, erythroplakia look like, red patch in the undersurface of the tongue. Another picture of erythroplakia which can go to squamous cell carcinoma. How would you confirm it? By taking a biopsy. You cannot rule out just saying, oh, this is not malignant, so nothing to worry. Do not reassure the patient until you yourself are reassured. So all these pre-malignant lesions, especially erythroleukopenia both, they need a biopsy to make sure that they are pre-malignant and not malignant yet. And we have to follow them on clinically. This is a picture of white leukopenia of the undersurface of tongue, side of the tongue, and floor of the mouth. Now, our management will be clinical examination and taking biopsies and then symptomatically treating and treat the causes which are affecting them like smoking, jagged tooth, poor dental hygiene. That has to be taken care. Coming to oral submucous fibrosis, this is pretty common in our practice, especially in urban areas of Sen. It presents with these features. Pallor of the oral cavity, look at it picture, oral cavities become very pale, the opening of mouth is limited, movement of the tongue is limited, and this is because of the submucous fibrosis under the mucosa. The cause is not known, but this happens usually to people who are using pan, chalia, gutkhas, and all those things. In the urban areas, this is very common. People are chewing chalia, pan, gutkhas. These are the presentations of oral submucous fibrosis. It starts slowly with burning sensation in the mouth, intolerance to chilies and things, and then difficulty in opening the mouth. So much so that hardly even a millimeter or two gap is left between the two teeth. And the tongue cannot be presented out. It causes a lot of difficulty in eating and chewing. And the cause, since the cause is with the areca nut, so we have to remove this chalia and areca nut from his habits and treat symptomatically. There is no cure for oral submucous fibrosis, medically or surgically. It's all symptomatic by giving physical therapy, physiotherapy, by stopping the offending agent, and by giving local long-acting steroids inside the oral cavity to relax it. Some surgical options are available, but they are all limited value. And of course, dental hygiene has to be attended with difficulty. These are some of the causes of causing submucous fibrosis. Coming next primary condition is Plummer-Vinson syndrome. These are especially middle-aged lady which are chronically iron deficient, presenting with all symptoms of oral deficiency like pallor, cholionicia, cheilitis, glossitis. Their tongue is very like ironed out, and difficulty in eating and swallowing. These are the clinical features of Plummer-Vinson syndrome, as I just mentioned. Because of the anemia, they also fatigue and feel very, very weak and loss of appetite. Now, the treatment, of course, will be on the cause and the effects. Cause is iron deficiency anemia, has to be treated with oral iron or injectable irons. And if there is a web in the cricopharynx or upper part of esophagus, that has to be broken by dilatation. Nowadays, by the gastroendoscopy group, the endoscopy group. Otherwise, we used to do as an ENT surgeon under anesthesia with a rigid esophagoscope and then passing dilated. But nowadays, these endoscopies are available. Like in our place, Dr. Munir is there. They do it a quick job, short job under short anesthesia, short sleep with minimal complications. Moving to the proper cancerous condition now, oral cancer. Oral cancer is a dreadful condition. We know it. All cancers are dangerous to life. So will be this one. Is pretty common in our society. Unfortunately, the same causes as we mentioned for oral mucous fibrosis, like poor dental hygiene, eating chalia, pan, gutka, and all those rubbish things available, freely available in the market. Most of them are habit related. The books are mentioning just to make you as a good mnemonics, like multiple essays, 5 or 6 essays, which include smoking, smoking cigarette, cigar, whatever, shisha, spirits, alcohol, and there's a combination of the two. They multiply geometrically, and the chances of getting malignancy are multifolded, not only double, multifolded. Then panchalia gutka definitely affects, it disturbs the epithelium and causes changes in the epithelium, metaplasia, dysplasia, and leading to frank carcinoma. Sharp dental age, of course, will make trouble. So syphilis used to cause problem. I haven't seen syphilis here long time, but is there in the differential diagnosis. Dental sepsis has to be attended, dental caries, and tobacco chewing. And some people are using tobacco chewing as well, either in the mouth, just keeping in the mouth, or in the pan gutka things. All these are carcinogens. One of them, or all of them can cause carcinogen, especially panchalia, smoking, and alcohol. Now, these are the presentations of oral carcinoma. This is a lady, young lady. She was treated for carcinoma tongue before, which has recurred again, and now it's fungating. Look at the mandible is exposed, and this tumor is all outside. The oral cavity, as we all know, it starts from lips to tongue, buccal mucosa, alveolar ridges, hard palate. This is all is oral cavity. So all this area can get carcinoma, like I'm showing in this picture. Carcinoma of the lower lip is there. All of them are in a different proportion, but in our population, common regions of oral cavity getting carcinomas are tongue, buccal mucosa, followed by other areas of the we've dealt with the causes. These are the picture we're going quickly. Undersurface of our tongue. Mostly it's the tongue is presented as having the maximum zone of oral cavity having carcinoma, followed by buccal cavity because of the habit of keeping pan, chalia, gutka as a quid and leaving it there for whole night or hours and hours, causing its damage. Now they present with an ulcer, malignant ulcer, non-healing ulcer. So any ulcer which is non-healing for more than a month needs to be looked into properly and has to be biopsied to prove that is it benign or is it very malignant, showing carcinoma in situ or frank carcinoma. Do not rule out just by clinical appearance. Please remember. These are one of the carcinogen in his mouth. You can see carcinoma of the buccal mucosa. Now, how do you diagnose? You diagnose by clinical history, examination. The ulcers are non-healing. They are taking long time, hours and hours, weeks and months, not healing with all our treatment you are given. You always rule out by doing a tissue biopsy, by incisional biopsy, and take investigations of scanning by CT scan or MRI. It would be ideal. We are always advised to take a MRI or CT scan before doing a biopsy because it disturbs the anatomy. The MRI and CT will show the 3D dimensions of the growth, ulcers involvement, deep involvement, as well as any lymph node involved or not. And then you can stage according to the classifications we know for all the carcinomas, all the cancers, TNM classification, like tumor size, size of the ulcer, T1, T2, T3, T4, along with either 2 centimeter, more than 2 centimeter, 4 centimeter, or more than 4 centimeter, and similarly involvement of lymph nodes, NO, N1, N2A, N2B, N3, and then classify. Similarly, we have a classification, of American classification as well, JACC. These all are there to stage the tumor. So all this tumor has to be diagnosed